Assalamu alaikum wa rahmatullah. Thank you very much for attending this session. We're going to talk about COVID as usual and the mutations, the Omicron, new treatment options, and new prophylaxis options. So let's start with old pandemics. In 1918, the Spanish flu hit the whole world and almost 50 million people died. And this compared to the current epidemic of SARS-CoV-2, this is nothing. Only we have around 6 million and a half people died, but the epidemic hasn't finished yet. So we have to be still cautious and well prepared. So let's talk about the mutations for COVID. First of all viruses mutate. This is the normal life of virus. Virus replicating in millions of copies. You'll get different mistakes in the DNA replication or RNA, whatever, and this will lead to mutation. So any change in the genome, with a single or more in the genome of the virus, is called mutation. This will lead to a new variant. So let's say Wuhan, the first, we call it the wild virus type, the first one in Wuhan is the original virus. After all those mutations going through alpha, beta, delta, and now Omicron, Omicron is another variant of the original wild virus. As I mentioned, viruses are always replicating, causing mutations. It's a normal phenomenon of the virus life. This is might be with no significance, but sometimes it does. It can change the virus transmissibility, severity of the disease, effectiveness of some treatments, or even detection of the virus and the diagnostic tools. How do we come out with such names? Alpha, beta, it is the Greek alphabet. And now the Omicron is the only variant of concern by WHO definition. Hopefully, will not jump to the next Greek letter, pi. Let's pray for that, inshallah. So again, as you can see, we started with the Wuhan original virus. We have all those variants from alpha, beta, till we reached Omicron, and Omicron have subvariants, sublineages, and BA.5 is the most common one or the dominant one. What do we know about the Omicron? Let's start from the upper left. It affected the efficacy of some monoclonal antibodies, but the treatment option is still okay, and the steroids still working, and the interleukin-6 antagonist still effective. Prevention, vaccines are still very protective, and we know that you can get a breakthrough infection, so you can get, even if you are vaccinated, cold-like symptoms, but it protects you against severe disease, against ICU admission or death, God forbid. What about transmissibility? New variants, including Omicron, the one I'm talking about, has higher rate of transmission, and reinfection Omicron is common. So you can get reinfected within a month within different sublineages of the Omicron variant. Imagine that the Wuhan original virus up in the left side was each person could infect up to 2 other people. Going to Delta, 1 person can infect up to 5 to 8 people. What about Omicron? Double this, so 1 person can infect up to 10 to 18 to 16 people. So high rate of transmissibility compared to the Wuhan wild type. What do we know about Omicron so far? Again, it's the dominant Omicron BA.5 dominant, carries additional mutations, and there's no evidence that this carries more severe disease unless you are unvaccinated. If you are unvaccinated or immunocompromised, it's a big deal. If you are vaccinated, we're in good shape. Finally, the new Omicron BA.5 caused less effectiveness, as I mentioned, of some monoclonal antibodies. Let's start with this case. This is a 66 years old male patient with past medical history of diabetes, coronary artery disease, and obesity. Diagnosed with COVID-19 infection. He's been having 2 days history of fever, body ache, but no cough or shortness of breath. His chest X-ray, as you can see, no obvious consolidation. He is having fever, but otherwise hemodynamically stable. Saturation is good on room air. So what option we have for such a patient? So let's go to the basics. COVID infection, SARS-CoV-2 virus course in humans have multiple stages. The first stage is what we call the viral replication, early in the disease, the first 5 to 7 days. And in this stage, you need every single immune cell in your body. Never, ever give steroids or any immunosuppressive therapy. All what we can give is antivirals and monoclonal antibodies. Later on, when the virus reaches the lung and causing hypoxemia, and we'll have what we call the hyperinflammation phase. This is when your immune system goes crazy, attacking every single part of your body, including the lung. And this is when you need to slow down the immune system. This is the time for steroids and for severe diseases, interleukin-6 antagonist. So again, for our patient, as you can see, he's still okay, not desaturating. So the options we have is antiviral and maybe monoclonal antibodies if he fulfills the criteria. If you are, what about the prophylaxis? Vaccines or EvoShield, the one we talked about in the morning, the tixavigimab, silgavimab. Once you have the hyperinflammatory phase with hypoxemia, then you can use, again, antivirals. You can use immunosuppressive therapy, including steroids and interleukin-6 antagonists. In early disease, what options we have? We have the Paxlovid, the Nirmatrelvir, ritonavir, and this is the Paxlovid. You can give it early in the disease when there is no pneumonia and there is no hypoxemia to high-risk population, up to 5 days from the beginning of the symptoms. You have to be aware of the drug-to-drug interaction. Remdesivir is still okay for early disease even without pneumonia, but 3 days. Once you have pneumonia, it's for 5 days. Then we have the monoclonal antibody approved, the only one approved right now. It's the bebtelovimab. Sotrovimab, it's still effective, but not as good as before. In vitro, it showed no effectiveness, but in vivo, we know still effective, but not as it was. We know that. Finally, molnupiravir, and this is also oral. You can give it up to 5 days from symptoms, but it has a marginal efficacy around 50%. So let's go through those cases and see what they have in common. So 66 years old female, a transplant kidney recipient. She is on immunosuppressive therapy, came with COVID infection. She's been having dyspnea and weakness for 2 weeks. She was vaccinated with 2 doses of Moderna vaccine. Last vaccine was 25 days ago. She is hypotensive, tachycardic, tachypneic, and her blood gases confirmed acute hypoxic respiratory failure. Saturation is low, and she needed high oxygen supplement. X-ray is shown, as you can see, there is interstitial infiltrates. The patient was confirmed with COVID-19 infection and admitted to the ICU, intubated. Dexamethasone was started, as well as remdesivir. She was not a candidate for monoclonal antibody. Why is that? Because she needs a lot of oxygen. She is desaturating. So despite all those measures, she continued to decompensate and died after 4 days. Second case, a 24 years old male patient with morbid obesity, and he had COVID-19 vaccine infection 6 months ago, developed chest pain 8 hours after receiving Moderna vaccine, and he was diagnosed with myocarditis, which can happen with messenger RNA vaccine, whether it's Moderna or Pfizer. Advised not to take COVID-19 vaccine at all. I think this might be a wrong decision because we have a lot of other kind of COVID vaccine. Shouldn't be always a messenger RNA. So the patient got infected with COVID-19 vaccine infection 4 months later. The patient had a severe disease, hypoxic, intubated, then extubated. He had a prolonged hospital course. And 4 months later, he's still suffering from what we call long COVID. He has generalized weakness, memory problem, cannot concentrate, cannot finish his job. So he had to quit his job or fired, whatever. And the patient is now very depressed. So could have anything been done for this patient? We'll find out. A third case is a 70-year-old male patient with malignant lymphoma on rituximab. 2 months ago, he was vaccinated. The patient now is being admitted with COVID. He's been having cough and shortness of breath for 7 days. The saturation is low, 91%, chest X-ray showing bilateral pleural effusion and bibasal infiltrates. During his hospitalization, received full course of DEXA, remdesivir, tocilizumab, but unfortunately the patient had to be intubated. And this is a CT scan, severe COVID pneumonia. The patient developed VAB, ventilator-associated pneumonia, and treated with amikacin, ceftolozane, tazobactam, because he had MDR pseudomonas, XDR pseudomonas, and then developed renal failure and died. Could have anything been done to those patients? What do they have in common? Number one, immunocompromised. Number two, one of them did not get the vaccine. So do we have any solution for such patients? Yes. We have tixagevimab, silgavimab, which we call it EvoShield, for patients who cannot get the vaccine for any reason or immunocompromised. And even if you give them vaccine, their immune system is messed up and the process of mounting antibodies is not okay. This long-acting monoclonal antibody is, again, given for patients of the age of 12 and above, and they have to be 40 kilos and above if they have moderate to severe immunosuppressive condition or they are not vaccinated. It was given the emergency use authorization by United Arab Emirates. So we come to a conclusion that vaccines cannot help all people. There's different categories. And those categories, as you can see, cancer, active chemotherapy, transplant, dialysis, immunosuppressive therapy, or patients with primary immunodeficiency cannot benefit from the vaccine. As you can see in the antibody mounting level in those immunocompromised patients, it is way less than normal control. So we have 4 slides to show you cases about EvoShield. So this is a 70-year-old female with a history of diabetes, coronary artery disease, and obesity. She developed severe allergic reaction to her first COVID vaccine. She refused to take any other COVID vaccine. Is there anything to give such a lady who is a high risk and might get severe disease and not fully vaccinated? The same concept, EvoShield. So who is at high risk of having severe disease? Let's go to our case. This is a lady who is above the age of 65. This is a high risk. She's obese. She has diabetes, and she has coronary artery disease. All these are risk factors for severe disease, and we could have helped her, or we can help her, using this injection. The second case is a 49-year-old patient with CLL, received 2 COVID vaccines, but he is worried that his immune response to the vaccine might be suboptimal, and we don't blame him. And he's asking, can he offer anything to help? The same concept. So let's go to evidence-based medicine. So for patients with CLL, the case fatality rate in general is 27%, very high. And this is whether you are vaccinated or not. This is a mixed pool. What about when you have a severe disease? It jumps to 38%, especially when you are older with cardiac failure or you are not treated for your CLL. And unfortunately, as you can see, for cancer patients, 62% 62% only receive vaccine. And out of those, how many will get benefit and mount antibodies and immunity? 58%. What about patients? I need 1 minute. What about patients who are with hematologic malignancy? The rate of response to the vaccines are really low, 19%. Imagine, severe low response to vaccine, COVID vaccine. The third case is a 48-year-old woman with a history of end-stage renal disease due to polycystic kidney disease. Patient developed severe COVID-19 pneumonia 2 weeks following her kidney transplant. She was vaccinated with 2 Pfizer vaccines, COVID-19, and the question was was there any way to help this lady, since we know she's going to be severely immunocompromised? And again, the same concept. In patients with organ transplant, solid organ transplant, as you can see, 46% will not mount enough antibody to protect them against COVID-19, whether after 1 or 2 vaccines. What about if we give a booster? Can it help? The answer, not a lot. As you can see, the antibody level after 3rd dose of vaccine, the booster, in those severely immunocompromised patients did not make any difference. Thank you very much.